Dr. A.C. Chaudhury, who is one of our course directors, to introduce Dilip Pahari, who we expect would join within a short while. And I request also Shotto to introduce Arpita, and you will also request Arpita to resume her master class. Shotto Ganguly, please.
Thank you, Amolda. Professor Dilip Pahari is my batchmate. He passed MBBS from Bankura Samudra Medical College with record marks. Then he did his post-graduation from IPGMER, then DM Nephrology from PGI Chandigarh, and worked as an professor in the Department of Nephrology, IPGMER. Then he left government service. Now he is the Chief of Nephrology in Medica Hospital, a brilliant fellow with many papers. Now I am also introducing Arpita. She passed MBBS from my alma mater, Neelottam Sarkar Medical College, and did her MD from Calcutta University and DM from the same university. Now she is probably head of the Department of Nephrology in IPGMER, and very good academician and a regular speaker of API and different forum, many papers in the different journals. I think all of we must enjoy our lecture. Thank you.
Sir, it's not a lecture, rather a didactic discussion. So thank you, API West Bengal, for inviting me in a faculty chair and for giving me the opportunity to teach so many medicine postgraduates. And myself, I think I practice a subspecialty of nephrology, the mother being the internal medicine, and I always enjoy discussions with internal medicine. So today's class, I first apologize. I'm suffering from upper RTI. Maybe sometimes my voice may croak. My student will be there to help. Dr. Shomudeep Kaur is a third-year PDT of nephrology DM in IPGMER course. He is also a very diligent worker in the wards and a very good reader. And I think he will do a good presentation today. Shomudeep, if you can start your case presentation, I am moving the slides. Not a single word. Not a single word from here. Shomudeep, you got it?
Yes, ma'am.
Yeah, start, please.
Good morning, my respected teachers. Today, I present a case with the story of a 50-year-old female. She was non-diabetic, hypothyroid, presented with generalized body swelling for 2 months, intermittent oral ulcer for 2 months, which was painless, occasional frothy urine for 2 months, decreased urine output for 1 month, and nausea and vomiting for 1 month. Before proceeding to the presenting illness, she had a history of frontal headache 2 weeks before this episode, and that time
Problem, Shomudeep? Of 50-year-old female.
Hello.
Shomudeep, you were present?
Yes, ma'am. But madam, the screen is not seen.
Other people can't see the screen?
Yes, it's visible.
It's visible. Shomudeep, you try. I'm starting.
We can see the screen.
Yes, madam.
Now your screen is visible, Shomudeep? Or
Yes,
I will start.
You start. Or
So she was a 50-year-old female, non-diabetic, hypothyroid, and not a known hypertensive. She presented with generalized body swelling for 2 months, intermittent oral ulcers for 2 months, and occasional frothy urine she had noticed 2 months back. So all this trouble started within few days, about 2 months back. From last 1 month, she has noticed a decreased urine output, and slightly she was feeling nauseating when she was taking food. So with these complaints, she visited a local physician who advised her some blood and urine test, because she told her that her urine got foamy and she was feeling nausea. So in the blood test, she was found to have azotemia, renal dysfunction, and her urine showed some protein. She received 1 unit PRBC in a local hospital and reached us. She was also having a frontal headache 2 weeks before this episode, and followed by detection of a new onset hypertension. She did not have any history of fever preceding this episode. She didn't have any lower urinary tract symptoms. She did not complain of any breathlessness or exertional dyspnea. She did not have cough and hemoptysis. Remember, all these negative histories will be very important in reducing our differential diagnosis to a single provisional diagnosis. So with this, we come to the next slide. The physical examination yielded moderate pallor, edema, and we found a single ulcer was present on the hard palate, which was non-tender, but no other ulcers were there. Neck vein was not engorged. She was not in frank volume overload. She had pedal edema alone, neither pleural effusion nor ascites on clinical examination. Her blood pressure she was mildly hypertensive, left arm supine, no postural drop, and her chest revealed bilateral vesicular breath sound, no crepitations, and cardiovascular system did not reveal any gallop rhythm. Her abdomen showed no fluid-trial shifting dullness, no ascites, as I have already mentioned, and there was no organomegaly. So urine dipstick did show some positive thing, that is, protein was 3+ and blood was 2+. So what are the positive findings we get? We get anemia on clinical examination and also confirmed in the blood test, as we have already availed from outside, some edema with proteinuria and hematuria, and hypertension, which is new onset, and there was RBCs in the urine, which we mentioned as active sediments in urine. With these, where do we stand? Let us go to the previous slide and let's discuss a bit of differential. So we could have thought the patient did have chronic renal failure. She is 50 years and she is a known hypothyroid. But 2 important risk factors which usually lead to chronic kidney disease at this age were missing. She was neither diabetic nor hypertensive, nor did she tell us history of any drug intake, NSAIDs or something which may, or arthritis and NSAIDs, which may have some role in precipitating the renal dysfunction. So background CKD seemed unlikely. Her story did not extend beyond 3 months. That is also an important marker, that whenever the history is little long, we more easily think about chronic kidney disease rather than an acute onset or a rapid onset glomerular disease. Because approach to these 3 categories of glomerular diseases are little different. So we did not consider CKD as the first diagnosis, but underlying some amount of chronic dysfunction, on top of that, some acute issues may be reported in this age group. suppose this female is postmenopausal, UTIs might have been quite common, and in presence of diabetes or even non-diabetes, if a virulent E. coli, she gets a urosepsis, she may land into active sediment in urine, and some amount of proteinuria might be accompanying in UTI also, renal dysfunction. So acute on chronic kidney disease may be a possibility in this lady. And next remains the other group, the rapidly progressive glomerular disease, which we will talk of later. And because of this significant protein in urine, which is 3+, in urine infection, we can get 1+ protein. But in 3+, we expect a close to nephrotic range proteinuria. We are more in favor of glomerular disease. Prior to admission, we had one urine REME report that showed even more albumin 4+, blood 4+, pus cell 12 to 14, RBCs plenty. These pus cells can be footprint of infection. It may also come in many other glomerular diseases where the glomerulus or interstitium is inflamed. So pus cell, when failed to show a culture growth, they may be representing some degree of inflammation in the interstitium or in the glomerular compartment. Urine ACR is 3426.4 milligram per gram. When we see very large proteinuria, we usually do not do ACR in our clinical practice in nephrology. I will be teaching a few slides. I will be talking about for our PGTs who can take their guide what to do first, whether to look at the albumin or whether to look at the total protein in urine. So you can see the urine in multiple pots with various colors, which can show you that how many information urine can give to you. With that, we move on to the dipstick, which we do have. It is a must-have thing in your ward, and you can have multiple, as I have in my ward, because we are concerned more with urine, or you can have at least 2 with you. That is, one is protein, one is blood, and am I audible? Am I audible, sir? Shomudi, did you find the screen? Would you like to present? So protein is there. Protein can be from trace to deep, which is 3+, 4+, and you can see the blood also here, which is while positive, the color is changing. These two are most important things for us, and we can have, of course, sugar, which is also important, and for us, ketone, pH, all are important also in the medicine ward. So it's better to have this dipstick, multi-component dipstick in your ward. And it shows, you can see high protein in urine along with active sediments in urine too. So it was from up to below. It is protein. You can see the green shade in the protein of this lady, and this blood, this is shown here. This is also a, you can see the blood stain close to this, which is also significant number of blood. Shomudeep, you can see. Would you like to take up? Yes. So tell them how we actually do the urine sediment analysis.
For the first step of urine sediment analysis, first we have to collect the urine. Spontaneous voided urine is the best sample to collect, and we have to transfer this sample to the lab within 2 hours of collection or 8 hours of refrigeration. Then we have to examine the urine. First, macroscopically, we have to examine the urine by color, clarity, and turbidity. And then we have to spin the urine. So for spinning the urine, so first we have to place 10 ml of urine in the centrifuge machine. Then it have to run for more than 1500 RPM for 5 minutes, and then we have to remove the 9.5 ml of supernatant and then gently resuspend the pellet and then plate the urine with a on the glass side with cover slip. And then we have to do the bright field or phase contrast microscopy and examine more than 10 fields at low power and high power field.
So urine examination is very crucial, and we did all these things in our departmental lab along with a phase contrast microscopy. Tell them, Shomurup, what are the Shomudeep, what are the actually dysmorphic RBCs, which are the footprint of the glomerular RBCs. You can see RBCs from the lower tract too, as happens in the prostatomegaly or urinary tract infection like cystitis, and you can have glomerular RBCs. Shomurup, highlight the difference between the dysmorphic RBCs and just crenated RBCs.
In this picture, so there is dysmorphic RBC and there is crenated RBC. So the dysmorphic RBC, they have the plasma membrane blebs and that are not regular, and that are the outpouching of the plasma membrane, and this is quite specific for the glomerular bleeding. And but the crenated RBC or the echinocytes, so there is the regular spikes. And that are
I'm showing the crenated RBCs there. Carry on, Shomudeep.
In this so the crenated RBC, they have the spikes on regular interval, but the acanthocytes, the blebs that are in not in regular interval, that they are widely spaced out, and these are quite specific for this glomerular bleeding. And more than 5% acanthocyte in total RBC in this specimen that are suggestive of this glomerular bleeding.
So from the microscopy, we can understand the blood is coming from glomerulus, and we expect some glomerular pathology there, which is very important in reaching the differential diagnosis. These are few casts, and Shomudeep, if you can take some, try to explain the casts and how important the casts are in differential of glomerular disease.
So the various type of cast, they can differentiate the various the glomerular from the interstitial diseases. So in the glomerular disease, the specific casts are the cellular cast. So like that is the WBC cast and the RBC cast. So and in the interstitial disease, so we can get the muddy brown cast and the renal tubular epithelial cell cast. So in this picture, we have seen on the left
the muddy brown cast
side on picture. So there is fine granular cast. On the B, there is the coarse granular cast. In C, there is the multiple fine, coarse, and muddy brown cast. And on the D, there is muddy brown cast. So the most important thing is that this muddy brown cast and the red blood cell cast, that should be seen in the low power field.
And tell them about the when we feel that this is, we are sure that the blood is coming from glomerulus when we see an RBC cast.
Yes, RBC cast is specific for glomerular diseases.
RBC cast is specific for glomerular disease. So when we get that, that is on top of a muddy brown cast or on top of a hyaline cast, it gets, the RBCs get entrapped, and we find that in urine, we are sure that these RBCs have originated from glomerulus, and while traveling down, they have been deposited on the casts which are increased due to ATN induced by proteinuria and the base of the cast is hyaline cast.
Yes, sir.
So with that, we move to the regarding proteinuria. A very complicated thing is now happening, that is, we are looking at urine albumin creatinine ratio and urine protein creatinine ratio. Let us see how they are different from each other. When we quantify urine protein and we look at a urine routine which is having protein 1+, having protein 3+ or more, we are more interested to look at the 24-hour urine protein, because we think that there is a high degree of proteinuria, and this is not only albumin, this is including proteins other than albumin. And while looking at the albumin, while looking at the whole protein, the 24-hour urine protein is important. It is gold standard because it includes the diurnal variation and gives us a picture of total urine protein excretion. But remember, 24-hour urine protein to be collected, a person has to be confined for 24 hours in a place. Many times that becomes impossible or difficult for a person to remain confined. So many times we may miss the urine. For children, we may not be able to collect 24-hour urine protein that way. So we have got into a relatively easier way of having a snapshot picture of 24-hour urine. That is the UPCR, urine protein creatinine ratio. What we do in 24-hour urine protein is on the numerator, and the denominator is the urinary creatinine. And this is a simple method of detecting proteinuria, where the diurnal variation will not be reflected, but we can have a rough idea of urine protein excretion. It correlates well with 24-hour urine protein excretion. So with that, we এখানে করবে না আজকে, করবে না এখন। Sorry, excuse me, মা ও এখন এখানে করবে না কিছু। So next comes the UACR, or urine albumin creatinine ratio. That is, you can go for UACR reflects like using creatinine as a denominator. We get a snapshot of the total albumin excretion by the kidney. So when to do what examination? When we are suspecting a nephrotic syndrome, nephrotic range proteinuria, we should go for a 24-hour protein excretion. It is one of the gold standard measurement for protein excretion recommended as initial evaluation. UPCR is a fast and simple method for evaluation of significant proteinuria. Sorry. So UPCR is a fast and simple method for detection of significant proteinuria and correlates well with 24-hour urine protein. UPCR results are influenced by GFR and urine creatinine because we are using it in the denominator. UPCR is both a screening test for proteinuria, monitoring assay in patients with lupus and other nephrotic syndrome, particularly when proteinuria goes above 1 gram. Several guidelines recommend the use of UACR for diabetic patients, while UPCR is applied for non-diabetic CKD. You can get UPCR even in diabetic patient. If you suspect that non-diabetic disease is likely to coexist with diabetic kidney disease, that is also a possibility, and you can get such cases. So proteinuria goal is variable depending on primary disease. Audible? Yeah. Am I audible? No issue? So more we use ACR in monitoring of diabetic patients, because ACR, they are the treatment target also. It is monitoring for the prognostication and treatment targeting. And as you can see, the degree of proteinuria, normal to mildly increased, we tell when it goes above 30, 30 to 299 is moderately increased, and severely increases more than 300. And urine PCR, as you can see, that urine protein dipstick is negative to trace in both these, and trace to 1+ in this area. And we expect PCR to measure this high proteinuria.
1 minute, Arpita. I think Professor Dilip Pahari has joined.
Oh, acha. Sir,
So any, this is a very interesting issue we have raised. So comments from or opinion from Professor Dilip Pahari.
So I think I can add a little bit. Say at the moment, if you send a urine sample to any lab, what they do actually, my one personal observation, they look the multisticks, they write the whatever the protein or the albumin, they check in the multisticks, and they check the urine maybe on that light microscope. But to be precise, there are 3 loopholes here. If you have a multiple myeloma, for example, the light chains are insensitive to the dipsticks. They don't are picked up by the dipsticks. So this is a major fallacy. If you have more globulin in the urine or some other diseases, which is not sensitive to the multisticks, you may miss out. It looks that there is a mild proteinuria on the multisticks, but there is actually in severe proteinuria. So this is one of the loopholes. The second loophole is the microscope. Unless you check under the so-called phase contrast microscope, you often miss the cellularity, whether it is RBC cast, WBC cast, or whether other casts, and the cellularity of the cells, which are not very clearly seen in the routine microscope. So you need a phase contrast microscope in most of the laboratory, and this one. Regarding the cast, classical of glomerulonephritis cast is classical of arthritis or disease, and antiform cast is significant of recovery of ATM.
Thank you, sir, for your great input. Yes, multiple myeloma is another situation where we cannot pick up the proteinuria in dipstick, and again 24-hour urine protein will be able to pick up the proteinuria present. And one such condition is amyloidosis related to multiple myeloma, where you can find a lot of protein in urine. So with that, I will request Shomudeep to again go back to the case and discuss it. For Professor Pahari, we have a phase contrast microscope in our department and we are using it. Thank you, sir, for the input.
Glad that the teaching institutions should have, but also the people who are reporting the lab actually, they should have, because otherwise you are misled by the interpretation of the urinary findings.
Yes, sir. Particularly for picking up dysmorphic RBCs, the phase contrast microscopy does excellent. Shomudeep, are you there?
Yes, ma'am.
Yes. Go with the case.
So going back to the case,
Professor Pahari, should I give you one line summary for the case?
No, I have heard. I'm to the beginning. I'm there.
Okay.
I have heard of it.
Thank you, sir.
Dr. Pahari অনেক আগে জয়েন করেছিলেন।
আচ্ছা।
অনেক আগে।
Shomudeep, please continue.
So before presenting to us the patient having the CBC with the hemoglobin of 7.5 gram%, total count of 500 and platelet of 1.4 lakh. With the peripheral blood smear, the normocytic normochromic type and retic count was 2.3%. So there is bicytopenia with normal corrected retic count. And after admission, we also see there is persistence of this anemia and bicytopenia, and initially there is also low platelet count, so there is pancytopenia. So gradually the total count improved. And then the renal function test prior to admission. So 2 weeks, sorry, initial first 2 months back, the creatinine was 1.54. So then after 2 weeks, that goes to 1.58. And 1 month back, it was 1.68. And 2 weeks back, it was 2.8. And after admission, her creatinine was 3.4 and urea was 153. And gradually her RFT gets deranged from 3.4 to 4.06 to 4.97. And the total protein was 4.5 to 5.2, and her albumin in the range of 1.4 to 2.5. Her uric acid was on the higher side, 14.3, 13.5, and the calcium was on the lower, little bit of lower side, but the corrected calcium was at about close to 9, and the phosphorus is on the higher side. And next.
So liver function tests were normal, Shomudi.
Yes,
so
liver function test were normal.
looking at the low albumin, significant proteinuria, a rapid jump of creatinine of 1.54 to 4.5 over 2 months, you are probably going to propose a diagnosis of rapidly progressive renal failure.
Yes,
and taking the protein and active sediments in urine, you will reduce the rapidly progressive renal failure diagnosis to rapidly progressive glomerulonephritis. So here comes our provisional diagnosis, which is we are first at rapidly progressive renal failure, which we reduce to rapidly progressive GN because of presence of significant proteinuria and active sediment in urine. We have a suggestion of thrombotic microangiopathy also in our mind, but in thrombotic microangiopathy alone, we did not get that much proteinuria. So it may come along with a glomerular disease, and we can see thrombotic microangiopathy along with a glomerular disease too, that we can see with IgA nephropathy, we can see with lupus nephritis. And second differential remains the acute on chronic kidney disease, which I told you that will always remain there because of this relatively elderly age, and she might have some degree of renal dysfunction, on top of which urosepsis may appear. As her urine did not show throughout the time any growth in culture sensitivity, and the patient did not give any history of lower urinary tract symptom, neither the typical pyelonephritis-like symptom of loin pain and abdominal pain and LUTs, we are more or less excluding urosepsis on clinical and lab basis.
Arpita, one thing, considering the ulcer on the heart palate, I think
yes, sir, we are coming. We are coming, sir.
Will be a very favorable diagnosis.
That said, sir, we are coming to. We will consider the renal plus extra-renal manifestation, and we will come to our possible diagnosis. So what sir was highlighting, the palatal ulcer was there, the anemia was there. Remember that in chronic kidney disease, anemia is an usual accompaniment and it reflects the part of renal failure symptoms. But in acute kidney disease, the anemia is not that a part of the disease. So when a short history of renal dysfunction along with anemia appears, to us, it is also a system involvement, that is the hemopoietic system. So hemopoietic system and the palatal ulcer and the renal dysfunction, we are probably in a multi-system disease rather than only glomerular disease. So not alone renal symptoms, we are looking at a multi-system involvement. So let us think in terms of that and move to the next slide. So Shomudi, if you can go through the investigations.
So with this multi-system involvement keeping in mind, so we proceed to the immunological profile. So in the immunological profile, the complement level, the C3 was on the lower side. So 18.3, C4 was normal, 20, NA was 4+ core speckled, anti-Smith was positive. And ANCA, MPO, PR3 and anti-GBM was negative. And also that is not written here, that the Platour antibody was also negative. So we also done the urine routine and microscopy examination in our lab with the phase contrast microscope. So that also detects that the dysmorphic RBC and the pass cell of 10 to 12, but there was no cellular cast. We did the urine PCR, that was 1.83. Her TSH was little bit of on higher side, that is 12.3. And ultrasound examination shows that the right kidney and left kidney of normal size, the cortical echogenicity was slightly raised, but there is normal corticomedullary differentiation. Infective parameter, that the procalcitonin was normal, and for anemia evaluation, we also done the LDH, which was also comes out normal, and the DCT was also negative. Chest X-ray reveals no abnormality, and echo, there is normal ejection fraction, and there is no regional motion abnormality, and there is grade 1 left ventricular diastolic dysfunction, and there is pericardial effusion.
Shomadip, with this much input, if you tell me how do you see anemia in lupus? Lupus comes in because ANA is 4+, C3 is low, and anti-Smith muscle is 2+, and you can propose lupus nephritis as a provisional diagnosis from this list. So how do you interpret the anemia? You have looked at the anemia with DCT negative. Is autoimmune hemolytic anemia is the only anemia that you see with lupus, or some other causes are also there?
No, madam. In lupus patients, the most common cause of anemia is the anemia of chronic disease.
Good.
And next is that is the nutritional anemia or the iron deficiency anemia. And another type of anemia that is the non-immune microangiopathic hemolytic anemia. That is DCT negative, but there is microangiopathic hemolytic anemia. So in this patient, I say that the patient is suffering from anemia of chronic disease.
So I will like to expand a little more, Shomadip. Whenever you are asked by your examiner that how do you interpret anemia in lupus can be due to the disease itself, also from the therapy part. So this is a patient in whom we didn't offer therapy. So this is purely the disease itself. And as you mentioned, that anemia of chronic disease, anemia of the autoimmune hemolytic or non-immune hemolytic anemia are the main causes, along with possibility of coexisting nutritional anemias. So from here, we would again want to highlight one thing that we see C3 is low. Can you tell me, Shomadip, that what pathway of the complement is involved in lupus, and what footprints of this pathway activation do you expect in lupus serology and in lupus biopsy?
In systemic lupus erythematosus, the classical pathway of complement activation is mainly activated, and yes, some sorts of alternative pathway of complement activation also plays an important role. And as the classical pathway is activated, we usually expect the deposition of Q in the kidney biopsy sample. And in the alternative pathway, there is deposition of the C3 in the specimen.
Okay. And as part of serology, you can always find C3 to be lower.
So C3 and
yeah. Let us
I think
come
I-
to the,
Hello.
hello.
I think there are two questions in the chat box. One is the role of ultrasound in deciding between acute and chronic. And another question is whether DCT negative, you can still have a immune hemolytic anemia or not. That's the
Yes,
two
we have
questions
already
in the
told.
chat box.
We have already told that there is a non-immune hemolytic anemia, autoimmune hemolytic anemia, which we may see in lupus. And in terms of USG showing chronic or acute disease, when in chronic disease, we can have, we usually have a small kidney size, and the corticomedullary differentiation is altered. The cortex is usually looks quite dark, which is comparable to the compared to the liver echogenicity, and liver's echogenicity compared to liver's echogenicity, it is quite dark, and the medulla is white. So we usually find this thing, corticomedullary differentiation preserved when the kidney is not diseased or acutely diseased. In acutely diseased, we may find some degree of enlargement of the kidney, some degree of increased attenuation. The cortex become even more dark because of the collection of fluid and edema being apparent there. But we do not see this typical blurring of corticomedullary distinction, that is the cortex started appearing white. So when the cortex becomes whitish and it changes its grade close to the liver echogenicity, we consider that the chronic renal failure stigma is there. So corticomedullary differentiation is altered there. What striking difference between cortex and medulla we usually see in normal kidney, that is lost, and we see a relatively whitish kidney with blurring of the corticomedullary differentiation. Is it okay, sir?
Now, I may add actually, the ultrasound actually, if you have a clear-cut case, means it is the acute short duration injury, you may have a one differential ultrasound, and it is a grossly chronic, then you have a different, what you are describing. Sometimes the disease is same borderline, maybe 3 months, 4 months ill, and then of which maybe 2 months symptomatic. So we often go for the kidney biopsy if the size is good. I think that also gives a clinical clue rather than rely on ultrasound. Sometimes both the size as well as this corticomedullary differentiation. You see, if you read the ultrasound by the various ultrasonography, it says that the normal, size is 9 centimeter and it looks normal. When the clinical picture is that of a CRF. So, if you have a borderline size, most people will go for a kidney biopsy rather than entirely dependent on ultrasound. Yes. Yes,
So
go ahead.
we pick up from here. That how to diagnose SLE on basis of, because we are now at a point that how we will be diagnose SLE. So Shomudi, will you like to explain the new ACR and Euler criteria and how it suits for your specific patient? Because remember, your patient offering SLE diagnosis to a postmenopausal lady, I will be really little confused with, I will think twice before putting that diagnosis. The generalized malaise and the fatigue along with this presentation, what this lady was reporting, I feel if it is seen clinically, many times we may look into the other rheumatological conditions like polymyalgia rheumatica, and you were describing one headache with polymyalgia rheumatica at age of 50. Sometimes we think of temporal arteritis, and this polymyalgia rheumatica we may get with other autoimmune diseases where arthritic symptoms are prominent. Those arthritic symptoms were not prominent in this lady, but there were a vague complaints of malaise and generalized body ache. Will you please take up this classification criteria and tell us how this lady goes into lupus domain, though she is little elderly?
So coming back to the case, so the patient presented with multi-system involvement with ANA positivity and low complement level. So the new ACR Euler criteria 2019 for classification of SLE, they that the patient must fulfill the entry criteria of ANA positivity of at least 1:80 on HEP2 cell line. So then at least 10 points should be there from this criteria. So in this criteria, so there is clinical domains and there is immunological domains. So in the clinical domain, so there is constitutional domain, cutaneous domain, arthritis domain, neurological domain, serositis domain, hematologic domain, and renal domain. And in the immunological domain, so there is antiphospholipid antibody domain, complement protein domain, and high specific antibodies domain. So in this patient, so there is ANA positivity with this, there is leukopenia with 3 points and thrombocytopenia of 4 points, but the autoimmune hemolysis is not included. So there is 7 points and proteinuria of more than 500 milligram. So includes the 4 points with low C3, that includes the 3 points. So that already crosses the 10 points. So we can classify. So,
even without biopsy, you can tell that this is lupus.
Yes, yes, ma'am.
Yes. So why then you are willing to do a biopsy on this lady? You are willing to do, no?
Yes, ma'am.
Yes.
We do biopsy in lupus, suspected lupus nephritis patient to categorize the class of this lupus nephritis and what is the activity, disease activity in this patient, and important thing is the prognostication. So how they behave with this treatment, and later on with if we need the protocol biopsy, then we can compare with this initial biopsy that how the disease progresses or how the disease respond to treatment.
So if you look at the, I will add up a little, Shomadip, for follow-up biopsies. Number one utility of biopsy is grading it, because if the biopsy is even after this is class 2, you may not need other than steroid unless your proteinuria is in nephrotic range. Then if the proteinuria is subnephrotic and your biopsy class is 2, the extrarenal symptoms domain is going to decide whether you need steroid or not. But if there is nephrotic range proteinuria with class 2, you are giving steroids. HCQ is a must, so steroid HCQ becomes the pattern. But if the class 3 or class 4, you need to increase immunosuppression to give a good outcome. And the repeat biopsies can monitor when the question of relapse come or changeover of the class comes, or the discontinuation of therapy also comes in place. Because there is a paper from Robin Bard that had shown that discontinuation of lupus is possible with minimum fear of relapse only if the chronicity and activity both go below 1. Okay. So we go to the next slide then after, that is the renal biopsy. And this is the histological classification of the renal biopsy. Will you take a beat through it, Shomadip?
Yes, ma'am. This is the ISN-RTS classification of lupus nephritis. So there is 6 class. So the class 1, that is the minimal mesangial lupus nephritis. So in the light microscopy, usually the glomeruli appear normal, but there is mesangial deposit in IF. In the class 2, there is mesangial proliferative lupus nephritis. So here we get the mesangial expansion and variable degree of mesangial hypercellularity with immune deposition that is detected by light microscopy and also by IF, and there is some sort of subendothelial deposition may be there. So in the class 3, so there is focal lupus nephritis, and here we get that is the active or inactive focal or segmental or global endocapillary or extracapillary hypercellularity that involving less than 50% of all glomeruli. In class 4, there is usually involvement of the more than 50% of glomeruli, and there is presence of usually class 3 and class 4. There is both class. There is presence of crescents, and in the class 4, there is important thing is there may be presence of fibrinoid necrosis, and there is extensive crescent may be there from class 3. So in the class 5, here we get that is the subepithelial immune deposition, and there is glomerular basement membrane thickening, and that may be associated with class 3 or class 4. And in class 6, so here we get the advanced sclerotic lupus nephritis, usually 90% more than equal to 90% of the glomeruli in global sclerosis.
So when you get class 6, usually think of not putting on immunosuppression because you are not able to recover. Extensive immunosuppression, you may decline, and you may get a class 3-5 combination or class 4-5 combination.
Yes.
With that, we proceed to the patient itself. This is a light microscopy. Shomadip,
One question here.
Yes.
The chat box, see the question whether you are going to treat a patient without biopsy. So is that biopsy, somebody is asking whether biopsy is mandatory or not. The other question is, my question is, you have to explain the chronicity and acute in all the biopsies, all categories, because
yes, sir, we have a slide. We have a slide showing the activity and chronicity. We will show it afterwards.
Okay,
and for the other question, we would like to do biopsy. We have already explained that how biopsies are helpful, because in presence of some important findings in biopsy, we rank the grade and the class of we attribute the class, and class is important for prognostication and treatment allocation. So that is the reason we go for biopsy. And you should do biopsy in this case, because blindly putting them on this elderly lady, excess immunosuppression will also harm her. So we need to go for a biopsy to justify a higher degree of immunosuppression.
Yeah, I want to mention one thing. Additional point of doing biopsy is that renal lupus may be associated with antiphospholipid syndrome. In renal biopsy, if you find only the glomerular change, then it is only lupus. But if along with glomerular changes, there is thrombosis in the small vessel, then you can assure that there is a double pathology, both lupus and antiphospholipid syndrome.
Yes.
And you will have to give warfarin-like drugs. So doing biopsy, I think, is a wise decision.
Sir, I have mentioned that thrombotic microangiopathy, which is an indirect footprint of phospholipid antibodies, is definitely a probability in this.
Where by doing a procedure, my treatment differs, then I will must do it.
Yes, thank you, sir. Yes, that is the reason we nephrologists are always willing to go with biopsy. Shomadip, you keep on describing the biopsy.
No. I have one here. See, what I have observed over the years, even though all nephrologists will do a biopsy, but SLE is being treated by the other people equal number, or if not more than the nephrologist treated SLE. So they don't do a biopsy. Develop a guideline for them. See the antiphospholipid, what is saying, antiphospholipid can check by the means.
Sir, for
yes,
students,
carry on. And because what I'm
for students, I will always do the ideal thing, sir. For students, we will always do the ideal thing.
I beg to differ with Professor Ahari. the SL is being treated by the rheumatologist, and we always go for kidney biopsy. Always is a dictum whenever a patient of SLE comes. If there is a slight doubt,
I mean, if everybody is doing a biopsy, is fine. It's fine. See, but I have seen a lot of people who are being treated without biopsy. That is what my observation. It's not I am not dictating.
Thank you, sir. Thank you, sir, for your input. Shomudip, if you can proceed with the biopsy.
Dr. Arpita Ray Chaudhury, may I pass a comment over here?
Yeah,
I'm Dr. P.S. Karmaka speaking.
Yes, of course, sir.
Yeah, so whatever Dr. Pahari has said, so far internists are concerned like us, we are really sometimes getting difficult to get the kidney biopsy done. And on clinical scenario and everything, what you have discussed is very nicely along with Somudip. So I am really in favor of Dr. Pahari's opinion that sometimes we have to treat because patient is in acute stage,
Yes,
and we have to treat with cyclophosphamide or something like that as the protocol says. So before getting biopsy. So
yes.
we are the internists which are facing this sort of problem. Thank you, sir. Over to Dr. Arpita Ray Chaudhury.
Thank you, Parthada. We will discuss it at the personal level that how we can make it easy for you. And Shomudip, if you proceed with the biopsy description.
So first, we have to so in light microscopy, so there is in the low power field with H and E stain, so there is two glomeruli are seen. So one in that is the at 7 o'clock position and one is the 11 o'clock position. So in the 7 o'clock 7 o'clock position, so 7 o'clock position, so there is the glomerulomegaly, and there is endocapillary there is increased cellularity of this glomeruli. So that is further commented on the high power field, and in the low power field also the glomeruli on the 11 o'clock position, there is slight sinking of glomeruli and there is presence of crescent.
This is a fibrocellular crescent in the glomeruli. And you can see the glomerulus is collapsing also. It's smaller in size, fibrosis ongoing. We can go to the high power field. This is the position 7 glomeruli. Shomudi, please describe. This is the mesangial expansion areas we are seeing.
So that
you go on describing, I will put the arrow on that.
That the glomeruli seen in the 7 o'clock position in this previous slide. So that is highlighted here in this left side image in the high power field. So in the H and E stain, so here we see there is mesangial matrix expansion with mesangial hypercellularity. Usually there is more than 2 cells in the mesangium, that then we call it at mesangial hypercellularity, and there is some points, so there is the capillary lumens are obliterated, and so and there is huge.
This is the obliterated capillary lumen. Yeah.
Yes. So there is lobular accentuation of this capillary lumen. So this is the membranoproliferative pattern of injury.
Okay, come to the crescentic slide.
Right hand side in the top images. So here is the PA stain. This so
gone a little fade. This is, yeah.
Yes, this PA stain, they usually highlighted the glomerular basement membrane. So the basement membrane characteristic that are usually better seen with this PA stain. So here we also seen that there is presence of one crescent, that is the fibrocellular crescent is there, and
the is broken over here,
and GBM is broken in this side. Yes, ma'am. And in the lower image, the right side, so this is the silver stain. So the silver stain, they actually depicts the GBM more beautifully.
There is some degree of thickening of GBM.
Yes, there is some degree of thickening of GBM, but there is no double contouring of GBM, and there is extensive circumferential crescent that is fibrocellular in nature.
The whole thing is a crescent. The glomerular cellular architecture is disorganized. This is a 3-cell layer crescent in which the fibrosis has already taken place. Okay, Shomuru?
Yes, sir. Yes, ma'am.
So this is the immunofluorescence, which again confirms lupus because of its full house picture, we call it.
Yes. Yes, ma'am. This immunofluorescence that in this slide, so there is IgG and IgM was positive, and also IgA was also positive, and the C3 also positive, and C1q also was positive.
This is very specific immunoglobulin for lupus, because lupus mainly activates the classical pathway, and C1q is the footprint of classical pathway activation.
So usually the full out house depicts that there is depletion of the 3 immunoglobulins, that is the IgG, IgM, and IgA, and there is depletion of the complement C3 and C1q. That depicts the full house pattern. So with
this is the way we report the biopsy. Yeah.
With this information, so we gave the final diagnosis of lupus nephritis class 4 with activity index of 12/24 and chronicity index of 2/12. So this is the chart from KDIGO 2021 guideline. So the components of activity index, that is the endocapillary hypercellularity, neutrophils or karyorrhexis, fibrinoid necrosis, hyaline deposit, or wear loop lesion or hyaline thrombi, cellular or fibrocellular crescent, and last the interstitial inflammation. So each
so this biopsy was having 3 for endocap hypercellularity,
neutrophil for 3,
neutrophil for 3, and
fibrocellular and fibrocellular crescent for 3, and the interstitial inflammation for 3.
That we got. So altogether 12, and chronicity was there only in terms of
chronicity was there in terms of fibrous crescent was there 1, so that is getting 1 point, and there is mild there is glomerulosclerosis. So this is the segmental glomerulosclerosis for 1 point. So there the interstitial fibrosis and tubular atrophy only in 5% glomeruli, so that get no point.
So chronicity guides us that chronicity is low, so this person must be treated to improve the activity index and give a good outcome of the treatment. So we will explain this elderly lady that we are going to treat her with highest possible immunosuppression, good immunosuppression, and the risks and benefits will have to be explained to her. Okay? Okay, Shomudeep?
Yes, ma'am.
Proceed for the next slide.
Yes.
Yeah. So if you just give them the guideline, and then we will pick up what we will do for this lady. We are at the end of discussion. Yeah.
This is the flowchart from KDIGO guideline 2021. So first we have to.
We are active class 4. Yeah.
Yes, this patient with active class 4. So already assessing the activity index of 12/21 and the chronicity index of 2/12. So this is the active class 4 lupus. So we proceed with this corticosteroid of methylprednisolone of 250 to 500 milligram for 3 days. Then prednisolone 0.6 to 1 milligram per kg per day, and then taper over months to maintenance dose. And also we have to give the cyclophosphamide according to the NIH protocol, and that is the 500 to 1 gram per meter square every monthly for 6 dose. And then we have to maintain with mycophenolate mofetil or azathioprine. Usually we continue with mycophenolate mofetil, And other options are there. We may give the Eurolupus protocol, that is the cyclophosphamide 500 milligram twice weekly for 6 dose, total 3 months, or we may continue with the multi-target therapy with cyclosporin, calcineurin inhibitor plus MMF plus steroid. But the thing is that the patient presented with the creatinine of more than 3, so we usually not put the patient on this multi-targeted therapy. We usually goes with this NIH protocol followed by.
Okay. Okay, Shomadip, from here I will take up. So SLE therapy has an induction phase and a maintenance phase. In the induction phase, idea is to hit the disease hard, and the maintenance phase is taking down your immunosuppression, which can keep the disease tempo down, but will not increase the side effects. This is the basic point behind how we treat a disease like lupus, which we are always afraid that can take a flare and can pounce on you like a panther. So for this elderly lady, we need to consider our therapy with little carefully, because we know that for a young lady who can tolerate the highest possible dose of cyclophosphamide, has the side effect of cyclophosphamide rather pushed to the end of life event. This lady who is in 50s may get even a malignancy event within 10 years with high dose of cyclophosphamide. So I was little cautious. We started with methylprednisone. Before that, we took care to exclude all infective conditions present, whether we need to treat with antibiotics or not. And then we started her on methylpred. By the time we went into the literature review, just that how the elderly lupus behaves. Is it more aggressive, as happens in pediatric lupus compared to the usual age lupus, or it is less aggressive than the young age lupus? Shomadip, if you can contribute a little for the literature review.
So from the literature review, so it is seen that the elderly lupus that are quite different from that is the young age lupus. So usually
we don't have any guideline for them as well. No, we don't have a guideline for elderly lupus. So we have to take it on take a personal take on it, and can formulate our therapy on basis of that personal take.
Yes.
Yes.
So usually the elderly lupus patients that are quite different from this young onset lupus. So usually they have much more insidious in onset, and there is usually more serositis, Zika symptom, Raynaud's phenomena, and neuropsychiatric symptoms are more in this age group compared to this young onset. In young onset, there is usually the photosensitivity, arthritis symptoms are much more prevalent. And in the serological part, in the young onset, the anti-dsDNA and hypocomplementemia is much more prevalent. But in elderly lupus, usually this anti-dsDNA and this hypocomplementemia is less prevalent. More prevalent anti-Rho antibody and anti-La antibody. So usually the patient
is expected to have not that aggressive outcome as we see in young lupus. So this patient so particularly, Shomadip, please.
Usually the contributory factor to this increased mortality in this group is maybe the old age and other comorbidity in these patients, and there is side effects of this therapy maybe contribute to the
mortality. So in elderly, whenever we are trying to put the elderly on immunosuppression, we should remember that we can push them or drag them to difficult situation because of the therapy related side effects too. So if I give my individual take, I would rather be interested to put the patient on a lower dose of cyclophosphamide as we provide in urolupus therapy, and then follow up that whether we can manage her on mycophenolate mofetil maintenance therapy. And if mycophenolate maintenance therapy works well for first 1 or 2 years, can we reduce them to azathioprine to even lower down the possibility of malignancy precipitating side effects or more infections in this age group. Thanks to luck that this lady didn't have much comorbidities with her, like diabetes and hypertension presenting from before, which could have been there and could have made our job even more difficult. But lupus always has a stake of hypertension, and we use ACE inhibitor ARB as primary therapy for that hypertension if the creatinine allows us to do that, because that will reduce proteinuria as well as address the hypertension too. Here we stop and we can answer and take the questions. And I will always be happy if I get a feedback that how did it work with you?
Arpita, I think now Professor Pahari will ask, interact, question, answer. And
Okay, sir.
No, few questions are there in the chat box. Why don't you see? They say the maintenance dose of steroid. How low is the dose of steroid?
We usually come down to 7.5 milligram by 3 months. And sometimes if it allows us, we can go as low as 5 milligram after 6 months. Steroids are really bad for this group of people. I cannot think of a steroid sparing protocol in lupus nephritis, but treating elderly with steroid really puts me in difficult situation because I'm afraid of osteoporosis. I'm afraid of bad DEXA, and frailty is another component which I think very, very strongly goes with Indian ladies. This frailty counts a lot. They get falls, they get fractures, and they meet a very poor quality of life.
Madam, can I comment over there? Dr. Pahari allows me. Dr. Dilip Pahari allows me, then I can comment. Dr. Bindu. Yeah. So one thing is that now the rheumatologists are going for the zero steroid or very, very low steroid. What's your experience about the very low steroid or zero steroid in maintenance of the renal nephropathy? I mean, SLE nephropathy.
Sorry, sir, I'm afraid. In European ethnicity, there is a Retux Lab trial by Liz Livingstone, which inspires some of the rheumatologists to go without steroid. I am afraid the class I treat, they cannot afford if they come with a dialysis requiring lupus flare. And I have seen many such off-steroid patients coming with dialysis requiring bad lupus and succumbing to infection and the disease activity. I never swallow this steroid-free protocol. I take all precautions, do DEXA, but I don't stop steroid unless I find that the biopsy shows activity chronicity very, very low, that is less than 1 or less than 2.
With permission of
very low
Professor
steroid.
Pahari, no,
very low.
that is not zero steroid. You can, they are saying that after 6 months, you go to lowest, that is 5 milligram.
5 milligram.
And another is give a short course of cyclo, 500 in a urolupus protocol for 6 doses, then go for rituximab, and in lower doses, 500 milligram every 15 days.
Sir, again,
also tries.
to be authentic, when I am teaching the students, excuse me, sir. When I'm rituximab well in observational and case series. But the RCTs failed. So for a specific situation, you may use rituximab, but for all using rituximab in lupus is, I will not recommend, sir.
Can I add here? So there, both US and other, they give a high dose of MMM. See, like 3 grams. Most of our patients, if you give 3 grams, they never tolerate. They come with the GI side effects. So we cannot afford to give that much of high dose of MMM. The steroid actually, if you give low dose of steroid in our transplants, and for kidney transplants, there was a time when people thought that the steroid-free transplant protocol is possibly good because it reduces diabetes, sugar control, osteoporosis, cataract, and so on. But then people have realized even the low dose of steroid is beneficial and prevents rejection in many. And if you are not giving the other immunosuppressor, both in rheumatology as well as transplants, then your chances of rejections and the relapse in disease is very high. So, all the protocols, low dose steroid is possibly the safest, and because you are not giving the other immunosuppression is very high dose. Voclosporin is one other drug which has not been discussed, but as well as belimumab and other drugs which are coming. I don't know what will be the eventual outcome with these drugs, but so far our protocol, I think low dose steroid is possibly the safest to use.
Yeah. Yeah.
Okay, Dilip.
Yeah.
Thank you for your sharing. Do you like to have the personal comment on the issue?
Okay. Dr. Pahari, I've got a question.
No,
Dr.
this is a
Pahari.
good teaching program. Yes, good. Carry on.
How low is the steroid to be given in a SLE nephropathy? What's your idea? Your experience? Yeah. How low?
You start with a bolus doses, you get the remission, you maintain the dose start around 30. You taper down. You can taper down to 5 or even 2.5 milligrams.
Yeah. That's my question. Okay.
2.5 milligrams.
Yes. Okay. Is there any role of combination of chemotherapy, combination of drugs, immunosuppression, steroid, except steroid, tacrolimus and mycophenolate combination, what they cannot tolerate?
Targeted therapy. The Chinese called it targeted therapy, tacrolimus, MMM, and steroid. These three together.
Yeah. Some of the southern people are starting also ketoconazole, keto augmented therapy in SLE nephropathy. Do you have any idea about both for the transplant as well as SLE patients? Ketoconazole augmented.
No, that ketoconazole increases your tacrolimus level or CNI level. So if you give a 200 milligram ketoconazole, you increase the dose of tacrolimus or cyclosporin by 80%.
Okay.
So you reduce the cost of the CNI. It does not offer any advantage. We had used this 30 years back. Now
but still CMC people are still giving it. So that's my question. Okay. Thank you very much.
Yeah.
So Amalda, I think I have finished my talk and you can continue the other part.
Okay. Now I request, I think there is a very excellent discussion, case-based discussion on SLE nephropathy. I request Dr. R.N. Sarkar, who is one of our course directors, to give vote of thanks for this excellent discussion.
Thank you, Amulda. Now it's my pleasure to thank first Arpita for an excellent this master class, and I must also thank Professor Pahari for highlighting the mainly important event things, and I must also thank my panelists and postgraduates who have joined in the class, and I also thank the API our Kaushik, who has given the logistics. Thank you.
Thank you, Dr. Arun Sarkar. Now, our next master class will be on 22nd of this month, that is 22nd January. We're going to discuss the multi-antibiotic resistant in ICU. I think that will be a very fascinating and clinically important issue. Now I adjourn this master class till next Sunday. Thank you to all.
Thank you.
Thank you, sir.
Thank you, everyone, speaker, chairperson, and panelists,
Or
as well as the participants. Thank you very much.
Mute kora ache, Arpita.
Thank you.
Okay.
Thank you. Thank you. Thank you.
Okay.